So today I'll be talking about vitamin B12 deficiency. Now coming to the fact how B12 is absorbed. So B12 in our food binds to haptocorrin. Haptocorrin is secreted by the salivary glands. Now this food goes into the intestines. Now vitamin B12 plus haptocorrin gets digested by the pancreatic enzymes. Now the haptocorrin gets separated and this vitamin B12 binds to the intrinsic factor. Intrinsic factor is secreted by what? Secreted by the parietal cells into the stomach. Now this vitamin B12 intrinsic factor complex enters the cell and get absorbed into the distal ileum. So the site of absorption of vitamin B12 is distal ileum. The site of secretion of intrinsic factor is parietal cells of the stomach, and haptocorrin is secreted by the salivary glands, which now it is absorbed from the distal ileum, enters the portal circulation and gets stored into the liver, and it is excreted majorly by the kidney. So this is the basic of absorption of vitamin B12. Now coming to the role of vitamin B12, homocysteine gets converted to methionine in the presence of vitamin B12, which further gets converted to S-adenosyl methionine, which gets further converted to S-adenosyl homocysteine, which gets converted back to homocysteine with the release of adenosyl. This homocysteine gets converted to cystathionin in the presence of vitamin B6, which gets further converted to cysteine in the presence of vitamin B6. Now, the reaction of conversion of homocysteine to methionine, there is demethylation of folate. 5-methyl tetrahydrofolate gets converted to tetrahydrofolate in this reaction. Now imagine that there is no B12. B12 is not there. So what will happen is homocysteine will not get converted to methionine and 5-methyl tetrahydrofolate will not get converted to tetrahydrofolate. This entity or phenomenon is known as folate trap. So why is it very important to study vitamin B12? Because vitamin B12 is required for two important enzymes. One is homocysteine gets converted to methionine in the presence of the enzyme for this is homocysteine methyl transferase. Then again, methionine is converted to methyl malonyl CoA, and this methyl malonyl CoA gets converted to succinyl CoA, which is further utilized in Krebs cycle. And the enzyme for this reaction is methyl malonyl CoA mutase. Right? Now this methyl, in the absence of B12, this reaction won't occur. So methyl malonyl CoA gets converted to methyl malonic acid. Now this accumulation of this methyl malonic acid is responsible for all the neuropathic symptoms in the deficiency of vitamin B12. So the two enzymes which require B12 are homocysteine methyl transferase and methyl malonyl CoA mutase. Now quickly brushing through the clinical features of vitamin B12 deficiency. One is hyperpigmentation, jaundice, vitiligo, pancytopenia, cognitive impairment, gait abnormalities, dementia, irritability, and peripheral neuropathy. So this thing is very important. So the changes that are seen along with treatment of B12 and what changes are seen first and what come later. So when you start giving B12, the first changes to see is LDH and bilirubin decline during the first 2 days. Then there is an increase in reticulocyte count within 3 to 4 days. Anemia starts to improve by 2 weeks and gets normalized within 4 to 8 weeks. Hypersegmented neutrophils disappear within 10 to 14 days. Leukopenia and thrombocytopenia resolve within 2 to 4 weeks. Neuropsychiatric symptoms improve over 3 months to 1 year. So the last symptom to improve after treatment of vitamin B12 are the neuropsychiatric symptoms. And the first change which can be seen is decrease in LDH and bilirubin. If that option is not there, then the first answer would be increased reticulocyte count. Now this is a image based question. This is a hyper-segmented neutrophil. The neutrophil contains usually more than 5 lobes, right? And in case of vitamin B12 deficiency, the nucleus is immature and not the cytoplasm. Now, coming to a very important test for vitamin B12 is Schilling's test. The main purpose of this is to diagnose pernicious anemia. So you give oral radio-labeled B12 and IM non-radio-labeled B12. IM non-radio-labeled B12 is to compensate the store deficiency. The patient urine is collected over next 24 hours. Normal test shows at least 10% of radio-labeled B12 is excreted in urine. This is the stage 1 of the test. Now coming to the stage 2 of the Schilling's test. If the first test is abnormal, test is repeated with additional intrinsic factor which is given orally. So intrinsic factor you give orally. If the second urine collection sample is normal, then diagnosis of pernicious anemia is confirmed and it is due to intrinsic factor deficiency. A low B12 on the second urine sample denotes malabsorption of vitamin B12. So we must know in what formulations vitamin B12 is available. So vitamin B12 is available in oral, sublingual, nasal and intramuscular forms. Formulations are available in hydroxycobalamin and cyanocobalamin forms.